Temporomandibular joint is the synovial articulation. We will have to talk about the gross anatomy, the surfaces of articulation, the intra-articular region, the membrane that surrounds it, and the synovial also fluid that fills it. And lastly, we have talked about the developing condyle, the primary and the secondary condyles, and the clinical considerations as usual. So when we say temporomandibular joint is a synovial articulation between the condyle of the mandible and the mandibular fossa in the temporal bone. So it is also known, it can be known as craniomandibular joint rather than temporomandibular. The being a synovial joint, it allows a considerable movements. So the joint cavity is filled with synovial fluid, and there is a synovial membrane that secretes the synovial fluid, which lines the internal surface of the joint capsule. We have a upper articular surface, lower articular surface that are primarily covered these uppermost areas or superficial area with fibrous tissue, and the cavity is divided by intra-articular disc to make it an upper synovial cavity and a lower synovial cavity. What makes the temporomandibular joint unusual or some way unique is the unusual features that the joint space here is divided into two joint cavities, upper and lower, by the intra-articular disc. So the upper joint cavity, it allows for gliding movement, while the lower joint cavity, it allows for hinge movements. These articular surfaces, secondly, they are not composed of hyaline cartilage as most of its type, but the TMJ is covered by fibrous tissue. And we'll know about it in the intramembranous development. The secondary condylar cartilage is present in the head of the condyle here, and which keeps growing until adolescence. And this is also an unusual feature. Fourth thing is that the movement of the jaw is influenced by the teeth also, the teeth location and intercuspation. This is again the upper articular eminence, the lower condylar head, which articulate together, of course, with the articulation with the mandibular fossa, what we call mandibular fossa or temporal fossa, or the glenoid fossa. Okay, and this is the articular disc that separates two synovial cavities, upper and lower. Other than the fossa and the condyle, we have the surrounding capsule that surrounds all of the temporomandibular joint. We have the ligaments. Main is temporomandibular ligament or the lateral ligament, and some accessory ligaments that holds or supports the TMJ in place. And lastly, we have a talk about the articular disc part. This is all not part of histology, but this is the part that is general gross anatomy. The mandibular fossa as the oval depression normally found in temporal bone, which is just anterior to the acoustic meatus. We have some variations, as we've said, according to occlusion of the teeth. The intra-articular disc, it molds the shape between the fossa and the condyle, so it has the same shape as upper fossa and lower condyle. In the condyle, we have variations in size and shape. The long axis is not at right angle, which is here. We don't have it at right angle, but at obtuse angle. The articular surfaces are the convex anterior and superior surface of the condyle. So we have also the ramus that joins the neck of the condyle here, and the upper articular surface are upper and anterior here. This is the gross anatomy. Now the capsule, it surrounds all of the TMJ. So if you want to say what is the TMJ, it's an encapsulated synovial hinge movement type of joint. The synovial joint, okay. So the capsule is a thin fibrous tissue, and it is very important that it does not limit the mandibular movement. The capsule is just a lining. It's very weak to provide any support to the joint. It only encapsulates the synovial fluid surrounding the joint. The capsule, it is attached to three parts: the glenoid fossa, the articular eminence also, both in the temporal bone, and it is attached beneath to the neck of the condyle. Posterior to the capsule, it is associated with the connective tissue of the intra-articular disc in the posterior region of the intra-articular disc, and we call it the retrodiscal pad. And internally, from the inside, it is attached to the interarticular disc, wholly attached from the inside, and it is wholly lined by something called the synovial membrane. The capsule is richly innervated. The synovial membrane, it lines the inner surface and it does not cover the articular surfaces. So it's only on the side of the capsule, but not the attachment of the capsule to the articular interarticular disc or articular surfaces. Note that the synovial membrane are specialized cells for secretion of synovial fluid, which has roles in filling the cavities, for lubrication, and nutritive functions. Here we go, attachment of the capsular ligament in the posterior part of the articular disc, and also attached to the fossa and eminence, and the neck of the condyle. The temporomandibular ligament, or what's called the lateral ligament, because it is lateral to the, it is located lateral to the capsule of the jaw. It is the part that strengthens the or supports the capsule, okay? Because it's a fibrous, dense fibrous connective tissue, it restricts the distal inferior mandibular movement. so that the condyle is not out of location or dislocated. It resists the dislocation during functional movement, and originally it starts in the lateral surface of the articular eminence and is inserted on the posterior surface of the condyle, as you can see here in the open jaw. We have, here is the joint capsule. Lateral to it, away from the midline, we have the lateral ligament or the temporomandibular ligament, which is the basic ligament that strengthens the TMJ. We have other accessory ligaments that help also. It's called secondary ligaments, such as the sphenomandibular ligament from the spheno to the mandible, and the stylomandibular ligament and pterygomandibular ligament and the retinacular ligaments. All of these have extensions from one process to the mandible. All of them, they insert to the mandible or the masseter muscle that is anterior, and they help to support. They have secondary functions of supporting the temporomandibular joint. Here is the 2 of the secondary ligaments. The other ones, the retinacular and the pterygomandibular, is found in the inner surface, okay, the medial surface. This is the temporomandibular ligament, which is too thick, and it has two parts, okay? I don't think it's written here, but the 2 parts of the temporomandibular ligament, it's found in your practical module, and will help you through it in the summary lecture, okay? All of this is cross anatomy. The articular disc, as an anatomy, it is dense fibrous. It has only from the periphery, it has the vasculature and innervation. The shape of this interarticular disc, which is a fibrous piece, okay? This fibrous piece has a shape that is upper concave or convex, okay? The shape of the eminence and fossa. And from the lower surface, it is concave to accommodate or mold the shape of the condyle. So it is in the central, it is thinnest, while the thickest part is posteriorly, because we said it has attachments to the capsule. Laterally, it is thinner than medially, and we have the capsule and the temporomandibular ligament laterally to strengthen the attachment. Shape of the intraarticular disc. Now, as also from anatomical part and from histological part, the articular disc is either extremities, medial, lateral, anterior, posterior, and we have the intermediate portion or the core portion. Now the extremities, we have the collagen fibers. They run in anterior, posterior, and mediolaterally. in all directions. Okay, the intermediate portion, which is the thinnest part, the core, it is in contact with the articular surface from the condyle, which keeps it in place. And as it's the moving, the condyle is the mandible is the moving part. And the collagen fibers only run anterior, from anterior to posterior part, only making it more regular. Okay. Here is the disc. At peripheries, it is merged with the capsule, as we've already mentioned. Anteriorly, it is attached to the anterior part of the articular eminence, and also from the anterior margin of the condyle. Posteriorly, it is attached to the capsule by something called bilaminar zone, which is superior and inferior thin layers of the disc. Medial and lateral, it is attached to the capsule. Here we go, the anterior, middle, and posterior parts of the disc. The posterior part is attached directly to the retrodiscal lamina, the superior and the inferior, and it is richly innervated, this part of the disc, and sensible. Posterior, intermediate, and anterior band of the disc, and they have different configurations histologically. This is the innervation of the disc, mostly by proprioception and nociception. The main cranial nerve is the trigeminal. Let's jump to the TMJ histology, which is our main part. Now we have the articular surfaces, the upper and the lower of the mandibular joint. We have 4 distinct layers that is described that cover the bony head of the condyle and of the fossa and eminence. So the most superficial layer, it forms the articular surface. It's composed of fibrous tissue. Although most of it is collagenous, but we some have also collagen, elastin fibers that have specific arrangement, okay, of running, how the collagen fibers they run. Also, the second beneath it is the cellular zone, we call it, that is beneath the articular surface. It is a more cell-rich zone, where proliferation occurs and provides a source of cells to the upper and lower layers, adjacent layers, replenishing, okay? The third beneath the cell-rich zone is called another fibrous layer that can have variable appearance. So we have some number of cells that are round, and we have round, like cartilaginous-like, and we have some other cells that are cartilage-like. So this layer is generally referred to as fibrocartilaginous layer. Beneath this fibrocartilaginous layer, we find the immediately covering the bone of the condyle, we have the calcified, thin zone of calcified cartilage, which is distinguished from the bone area by some properties that are different, okay? The calcified cartilage here, it's a remnant of the secondary condylar cartilage, which we'll talk about. Now the articular surface that covers the upper part, which is the mandibular fossa of the temporal bone, is similar to that of the condyle, similar to this, although generally it is thinner and it thickens while it passes over the articular eminence. And we have something called crimping. It's different also in the upper. Here is all of the lower surface, starting from articular disc, the lower synovial fluid, the lower synovial cavity, and the 1, 2, 3, 4 layers covering the bone. Okay, the bone of the condyle. This is from the upper side, upper to the articular disc, the upper cavity, synovial cavity, and we have these articular zone, proliferative zone, and fibrocartilaginous zone because we don't have the calcified cartilage in the upper part. It directly covers the temporal bone. While we said in the eminence, it looks more thicker than over the fossa. Okay. Otherwise, generally, this is the configuration. The intra-articular disc, gross anatomy, we've said about it, how it's been described. Like other soft, dense connective tissues, this disc, it contains cells that are embedded in a matrix. The matrix composes of fibers and ground substance. Okay, so the majority of fibers, they consist of collagen type 1, these fibers, and mostly the ground substance, we have it, the other contents, but collagen fibers, they have type 1 mostly. Elastin fibers also we can find, and mostly it is of water, so 80% of the disc is composed of water. Here is where is the ground substance? Here is the chemical composition. So type 1, type 2, type 3, sorry, type 2 also, it's localized in some areas, especially the middle area. Elastin fibers, and the ground substance, which is 5% of dry weight. It is it has the 3 parts, okay, the chondroitin sulfate, most of it, dermatan sulfate, and some traces of hyaluronan and heparan sulfate. Okay, because of this anionic charging through this ground substance, this glycosaminoglycans will have absorbing of the water, so they adapt the intra-articular disc to resist any compressive loading. These are the major glycosaminoglycans that are present. So we have the compressive loading in one part. It is found as crimping. Let's go back. In one part of that is compressed in the where we don't have the GAGs, the chondroitin sulfate associated, the compressive loading will generate tensional loads elsewhere that can be resisted by the crimping of collagen fibers. We call it crimps or waviness. And they can be found under the electron microscope as dark and light bands. The cells population that are present in the disc are the we have more numerous at birth, okay, at time of birth, and they become sparsely distributed in the adult time. the cells, they show an outline varying between flattened and rounded cells, so fibroblast-like cells and chondrocyte-like cells. The more rounded cells, they have high amount of cytoplasm, and we don't know really about the cell kinetics and the apoptic activity, but mostly it's the cells, they stay for the whole lifespan, okay? And to do a degree of cell proliferation, because cell proliferation is more remarkable at birth, okay, or in the early ages. It's rapid degree of cell proliferation. Now at ultrastructural level, we have some intermediate, we have moderate amounts of, here we say, in the fibroblasts, we have synthesis and secretion of extracellular matrix. So we have endoplasmic reticulum, mitochondria, Golgi apparatus, vesicles, to produce the considerable amount of the what we say extracellular matrix, okay? But in intermediate, we have also considerable quantities of intermediate filaments differing in diameter. We have the cell membrane is closely opposed to the collagen fibrils of the extracellular matrix, directly adjacent to it. Now, the fluorescent microscope will tell me if it's a fibroblast or a fibrocyte, as the fibrocartilaginous area is full of numerous fibroblasts in the neonates, okay, in the early stage, especially. The fibrocartilaginous area, we will see a of the articular disc, of course. We see the rounded appearance, fibroblast-like cells. We have the cartilage-like cells also. We have also the peripheral matrix. The peripheral matrix, we say that most of the cells are found in the outermost layers, okay? But the peripheral matrix, it surrounds the cells from all over. Now we have the, here is the interarticular disc. We have the part that is older disc in the early, but we have the cartilaginous-like cells that have all around the extracellular matrix. And now it's associated to the secretion and turnover of the extracellular matrix. We have a reasonably active fibroblast-like cells. Okay, we don't have here a, we have it in your practical session. The fibroblasts are reasonably active to produce amounts of the extracellular matrix, okay? And we have also gap junctions and synthesis of junctions to make the turnover of collagen slower. You could have some cells that are called fibrocytes also, okay? And we have a supporting hypothesis that we have absence of intercellular collagen profiles in the fibrocytes that makes the rapid turnover of collagen. So normally we have collagen type 2. We have high molecular weight, the GAGs, the chondroitin sulfate, proteoglycans. We have the pericellular matrix surrounding the cells. We have the chondrocyte-like cells, which have rounded morphology. And we have no cell contacts. We have absence of blood vessels within the tissue. With regard to the features that we've said above, the intra-articular disc, it lacks any blood vessels in the central portion. So here it's avascular, but it exhibits high molecular weight chondroitin sulfates and GAGs in the middle, in this middle portion. Okay. However, we have the term fibrochondrocytes that can be found also, that was discovered, and the nutrition in the peripheral part, we have, it's highly, we can have highly amounts of blood vessels. Okay. Moving to the synovial membrane, it lines, as we've said, the inner surface, internal surface of the capsule. It does not cover the articular surface, and this is important. It lines, it is the margins of the interarticular disc and the fibrous capsule of the TMJ. It is lined by the synovial membrane. Now, it's obviously we don't have covering to the articular surfaces because they are rapidly worn away. We have rapid turnover for wearing of the articular surfaces. The synovial membrane consists of, histologically, layer of flattened endothelial-like cells, which are resting on a vascular layer. And these cells have two types: macrophage-like cells and fibroblast-like cells. The macrophage, they are phagocytic, okay, and we have the fibroblast, normal fibroblast-like cell type. The synovial membrane, it shows high metabolic activity, so we have high regeneration potential of this membrane. We can have some stem cells from this synovial membrane. It secretes, as function, that it secretes the synovial fluid, which occupies the joint capsule. The inferior cavity, it has 1 ml almost here in the inferior cavity, while it is slightly larger amounts in the superior joint cavity. It has some little more. The synovial fluid has lubrication, it gives lubrication for the joint, and important components also are the proteoglycans, we've said, okay? Proteoglycans, which gives this easy of movement. The hyaluronan also can bind, giving non-adherent surface. Normal synovial fluid, it contains pro-inflammatory cytokines, interleukins, and tumor necrosis factors, okay? To oppose or to oppose to the disorders of the temporomandibular joint. Okay, so it gives it some protection and defense. At rest, the hydrostatic pressure of the synovial fluid, it is subatmospheric, but generally during mastication it gets elevated. Raised fluid pressures may be clinically also relevant, okay, especially patients with bruxism that keep have high stress, keep the temporomandibular joint highly stressed, okay. Now this is, we've reached to the end of the lecture talking about the condyle of the child. We'll have just quick, and I'll make for you as easy in the summary lecture, okay? Because we don't have time. In the summary lecture, I'll make it more easy, the summarizing of all the embryo, and this is part of the embryo also, the developing condyle. Now, histological appearance of the mandibular condyle, it is varied with age. So we have primary and we have secondary. Because of the presence of the secondary condylar cartilage that is found in childhood, okay? So the cartilage, it appears initially at 10th week intrauterine, and remains as a zone of proliferation cartilage until adolescence, until about 16 years of age. So, like the adult, the mandibular condyle of the child, it is lined by a layer of fibrous tissue. Beneath it is a layer of proliferative layer, undifferentiated cells, which has more activity. Cells from this proliferation layer, which is found just beneath, here you find the cell-rich zone. Cells here are will give rise to fibroblast-like cells and will subsequently differentiate to chondrocytes, which gives the secondary condylar cartilage. The main as cartilage, it is chiefly here, the main collagen is collagen type 2, okay, briefly, or chiefly. The chondrocytes in the deep part here in the condylar cartilage, we have hypertrophic region, so we call it the increased in size, so we call it the hypertrophic area, okay, hypertrophic condylar cartilage or chondrocytes. And after that, it follows the region of the endochondral ossification. If you want to say brief about the endochondral ossification, this is your last slide, but briefly, it involves the mineralization of the cartilage matrix and subsequent apoptosis of the hypertrophic chondrocytes. Part of the calcified cartilage is resorbed by large multinucleated osteoclasts that are found here. Subsequently, we find bone-forming cells, the osteoblasts, which deposit, we know, the woven bone, the trabecular bone, okay, and around the calcified cartilage area. Eventually, this area will be remodeled to produce the more mature bone. But unlike the chondrocytes in typical normal plates, deep chondrocytes here in the condyle are not aligned. We say that they are not aligned into columns, and they do not secrete as much of intercellular matrix. Possibly, we have the condylar cartilage that keeps growing for the growth of the mandible, okay? And in young children, it is you see that it is not lined by mature bone. If I give you a section, you see that in child condyle, or in young child, it is not lined by a distinct layer of compact bone, as you find in the adult. This is the final part, talking about primary versus secondary, and some it is present in the practical module about the spheno-occipital synchondrosis, okay, which we say that the primary cartilage, we have it appears as it has some fibroblast-like cells, undifferentiated like cells that go into proliferation. We have some growth forces that makes different extracellular matrix development, okay, less production actually. And we have the difference in the alignment of the hypertrophic chondrocytes into columns or haphazard, by default, haphazard alignments, okay? So you'll have the secondary cartilage. It will produce some growth in more than one direction. But in the case of, as opposed to synchondrosis, we have the epiphyseal growth plate, columns of cartilage that are found on only one side of cartilage, okay? For clinical considerations, we have multifactorial disorders of the temporomandibular joint. Most conditions that have the ankylosis of the condyle dislocation of the condyle, displacement before and then dislocation. This is during the movement of the TMJ. We can have some inflammatory and degenerative conditions such as the rheumatoid arthritis and the osteoarthritis. About the intra-articular disc, it may gradually become displaced from its normal position between the articular discs, the articular surfaces, and we can have some degenerative changes in the disc that are seen. It may reach to invasion of the perforation. Okay, the disc may have perforation because the loss of the structure, loss or wearing of structure in the internal, in the disc, it will cause the perforation and invasion to blood vessels. Okay. Now, we have also occlusal changes that might lead to changes in the TMJ also because we have interrelation that is described in the summary part. Okay. Now there is difficulty in treating these conditions because we don't have high healing properties. Perhaps it's related to the lack of blood vessels in the intra-articular disc area, in the central part. Okay. But the mandible generally it develops at greater or lesser rate than the maxilla. So during in children we might have some malocclusion, imbalance in malocclusion or facial disharmony, and it leads definitely to changes in the TMJ intervention. Okay, let's say in the growth of the TMJ and the mandible area, contributing or back to the secondary condylar cartilage. Okay, all of these differences, you will have them seen in the summary. This is the end of the course.